Well, we have a really special grand rounds today. We have a few updates we want to get through pretty quickly, so we have lots of time for our honored speaker today. For those of you who know Dr. Verghese Abraham, he's actually on he's on Zoom right now, but he wanted to stay quiet. I just wanted to say a few words. He's had a busy couple days. As many of you know, he's had a book that came out many, many years ago, Cutting for Stone, and then he's been working on a new book for the last 10 plus years, Covenant of Water. Yesterday it released. And we were all surprised to see him first start the morning with Oprah Winfrey, who endorsed his book and also said it's one of the top 3 books she's ever read in her entire life. So pretty much the best type of, yeah. Abraham, I hope you can hear all that clapping. I'm sure there's a lot of clapping online too. I know there is actually. So, Abraham's been a mentor of mine, and he's run grand rounds the whole time he's writing this book as well, by the way. So it's so fitting we get to mention it this morning. So congratulations to you. We're so proud of you and how you represent our whole department and community. So looking forward to seeing more. You saw the newsletter came out yesterday, and we'll certainly share more about upcoming events. We're going to do a special event for him too, but he's traveling around the country doing tours right now, starting today in LA. That being said, I'm now going to turn it over to Dr. Harmon.
Great. Thanks so much, Dr. Hostalga. It is my pleasure to announce several events happening this month. It is Asian American Pacific Islander Heritage Month, as well as Mental Health Awareness Month. The first is our next Grand Round speaker, which will be virtual, is Dr. Tan Neville. She is an intensivist at UCLA, and she'll be speaking on the 3 Wishes Project and bringing compassion back into healthcare. And so stay tuned for that. That's next week. Next, I wanted to announce several events that are being hosted by our CARE Center on campus, Center for Asian Health Research and Education. The first is a panel on what it means to be Asian in America. The speakers include Neil Ruiz, who is the Associate Director of Race and Ethnicity Research at the Pew Research Center, Dr. Russell Jung, who is a Professor of Asian American Studies at San Francisco State and the co-founder of Stop AAPI Hate, our own very Professor, Dr. Malathi Srinivasan, who is a clinical professor here in primary care and population health, and Dr. Richard Pan, who is a senior advisor to the Stop AAPI Hate organization, as well as a former state senator for California. The next event, which will be on May 15th, is a more local event featuring the journeys of Asian leaders here at Stanford Medicine. And that will include myself, actually, and Tip Kim, who is our Chief Market Development Officer for Stanford Medicine, Andao Huang, who is the Director of Perioperative Anesthesia, and Dr. Kekoa Tapara, who is a radiation oncology resident here at Stanford. Lastly, in honor of both Mental Health Awareness Month and Asian American Pacific Islander Heritage Month, there will be a screening both in person and on virtual of a documentary film called Try Harder on engaging Asian youth here in America in mental health and mental health awareness. And that will include the producer, Debbie Lum, Dr. Rona Hu is a professor of psychiatry here at Stanford, Cassie Zhao, who is, never heard this position before, Chief Laughing Officer at Laugh It Out Hub. And yes, and Kian Mojabi, who is a high school student from Lowell, locally here, who was featured in the film. So thank you. And I will pass it on to Dr. Dunn for several more announcements.
Thank you. Thank you, Dr. Harmon. Good morning, everyone. Let's see. Just waiting for the next slide to come up. I have a few announcements. Oh, do you? Okay, I'm looking at that. I'm like, I don't see it. Okay, well, that being said, as part of our goals of becoming an anti-racist department, Dr. Salas and I have been discussing Nicole Hannah-Jones's groundbreaking 1619 project, and we will be having a discussion on episode 5 coming up next week on May 8th. That her project puts slavery at the center of our U.S. narrative and shows all the ways it impacts our lives today. So that will be May 8th. It is virtual and it'll be at 5 p.m. And hopefully we'll be putting the link in the chat, or there's a QR code on your screen where you can register. All right. And then we have the annual Diversity Inclusion Forum that is co-hosted by the ODME as well as the OFDD. And that will be an opportunity to see a wonderful keynote speaker, Dr. Divika Bhushan, who is our previous Surgeon General here in California and former resident at Stanford. And you will see the culmination of all the hard work of the lead scholars, Leadership Education for Advancing Diversity scholars. They have put an incredible amount of work into these workshops that focus on DEI topics and promoting DEI and encouraging all of us to be better as a community. And I hope that you will come and support them. It promises to be an incredible day. That's going to be Friday, May 12th from 8 o'clock till 1 p.m. And you can scan the QR code to register, or we can put that in the chat. Thanks so much. And I'm going to hand it over to Dr. Shah.
Actually, the next slide. Thank you so much. As our Associate Chair for Community Partnership, it's my true privilege and honor to be co-hosting our speaker, Dr. Aguilar-Gaxiola, today with our peers from the Office of Community Engagement, specifically Dr. Lisa Goldman-Rosas, who's the Director of Stanford Medicine's Office of Community Engagement, and Associate Director of Research, Patricia Espinosa. And this kicks off a theme for this month, which is community engagement that is brought out in a couple other of our grand rounds, and specifically examples of how bidirectional partnership between academia and the community can be key in promoting and advancing health equity. Specifically, on the 24th, we will have two of our Diversity Chair Investigator awardees sharing their work. Dr. Robert Wang sharing his Neighbors project, and Dr. Tem Moldesis sharing his Cut Hypertension work, a barbershop-based project. And then at the end of the month, we'll hear from our residency leadership, APD, Dr. Wendy Caceres, and Chief Resident, Christine Santiago. Dr. Santiago will be sharing the program that she launched with her peers, a residency program focused on, called Health Equity Advocacy and Research, I Am Here's, and really has been crucial for our growing cadre of residents who are passionate about advocacy and caring for underserved communities. Lastly, actually, go back to the other slide, sorry for the reverse order. Lastly, I want to share a couple opportunities and resources for our community partnership program, which launched last year, really with the goal of supporting and building pathways towards community engagement across all of our divisions and all our specialties. And so to that end, Alex Blacker, my program director, and I have launched Council, the Community Partnership Council that meets monthly. We'd love to have representation from all of the divisions, about half are represented now. So if you're interested, this really is a learning community. So whether you're aspiring to get involved in the space or already have projects that are community engaged, it's an opportunity for us to get together and learn from each other. So please reach out if you're interested in learning more, or who from your division is participating in that. Lastly, before I turn it over to my colleagues from the Office of Community Engagement, I want to share that there is a technical assistance request that OCE, Office of Community Engagement, created, but now is generously shared with many of our community engaged hubs as a one-point entry for requests for help, wisdom, expertise on how to engage with the community, really across all pillars, not only research, but if you're looking for capacity building, bidirectional partnerships, or community engaged education opportunities. So you can scan this or find it on our website, on OCE's website. They've been amazing resource and support as we build our own program. And I would really urge, especially our researchers, as the department endeavors on the team science direction and larger projects that will tackle health equity and inherently have to go outside our own walls, please remember that the OCE and Lisa and her team are an amazing resource. So with that, I will pass it over to Dr. Goldman-Rosas to introduce our speaker.
Thank you so much, Jonathan. So I am the only person standing between us and a wonderful talk, so I am going to be very brief. Thanks, Jonathan, for the introduction. On behalf of myself, Patricia Rodriguez Espinosa, Wei Ting Chen, our leadership in the Office of Community Engagement, we are thrilled to host our friend and colleague from up the road at UC Davis. So Dr. Sergio Aguilar-Gaxiola is a professor of internal medicine at the UC Davis School of Medicine, and he is the founding director of the Center for Reducing Health Disparities at UC Davis Health, and also their director of community engagement for their CTSA, a role that we share. We have had the great honor and privilege of getting to know Dr. Aguilar-Gaxiola over the last 3 years during the pandemic as part of a statewide consortium. And trust me when I tell you, you will feel more energized about your work, better about the world, and perhaps even better about yourself after listening to Sergio for the next 40 minutes. But let me just tell you a little bit about him. He is a national and international expert on health and mental health equity. He is the author of over 190 publications, the recipient of multiple international, national, and importantly, local awards for his work in the community. He holds several leadership positions nationally in community engagement. So all of the CTSA community engagement cores have a committee which he has chaired. He also is on the NCATS National Advisory Board. He holds several national leadership positions addressing mental health disparities as well, such as the National Advisory Mental Health Council for NIMH. In our state, he is also a recognized leader, and I understand in 2022, he was appointed to the Governor's Advisory Council on Physical Fitness and Mental Well-Being and is chair of the Best Practices Committee, so we are in good hands. His own research uses applied and translational research to focus on identifying unmet health and mental health needs. And he really focuses on translating his findings into practices and policies in the community, especially in our migrant health communities throughout the state, which I really admire and appreciate. So hopefully I was quick enough to leave you enough time, Sergio, and I'm so looking forward to your talk.
Thank you so much. I appreciate it, Lisa. Can you hear me?
Yes.
Yes, okay. Well, I'm delighted to be here, truly delighted. And not only because meeting with dear colleagues that we have been working together so closely in the last 3 years or so, but also new friends and new colleagues here at Stanford and some collaborations that we're hoping to start soon as well. And what I will be sharing with you is basically a response to a question that has guided me for the last perhaps nearly 4 decades. I have been working on the health equity, mental health equity space for years. And this question that you see on the screen, is it possible to advance mental health equity in historically underserved communities? And in our case, through community engaged approaches. So for the rest of the talk, I'm hoping to present to you some of the things that we did in transforming mental health service delivery at a county, and also to share an answer, at least in part, an answer to this question. And I will also share with you the kind of work that we are doing currently, and which is kind of a paradigmatic shift on service delivery, health service delivery. So it's ambitious because I have very limited time, but let's see how much we are able to cover. This is, I'm a member of the National Advisory Council of SAMHSA, the clinical mental health services. And they give us these reports to the council members quarterly. And this is a report that happened in 2008. And it is for Latinos specifically, And the report is on 12 and older, although some of the information that I will share with you, like this one right here, is to those 18 and older. And back in 2018, out of this category here, this is folks that really need services. These are those with co-occurring any mental illness and substance use disorders, okay? Really, really are in need. 93% of Latinos receive no treatment for this condition, okay? And look at this. This is substance use disorders, and this includes 12 and older. It's 90% who are not receiving treatment. This is for African Americans also, 2018. And the statistics are not that different. This is 91% with no treatment for co-occurring disorders. And so one of the things that I want to emphasize is that you would say, oh my, this is dismaying. But the 2019 data is a little bit worse. It's 94% of Latinos not receiving services. And the 2020, 95%. We are going on the wrong direction. And I believe that during the pandemic, this has been exacerbated even further. So the need for mental health services for populations like Latinos, African Americans, and other underserved populations cannot be clearer. So now I'm moving to the work that we did in Solano County. I think that it was 2015, maybe 2015. The then director of the Behavioral Health Division, someone that I knew, and 3 of his leadership team members came to see me and to the center that I direct. And they said, you know, we have a need and we have some demands from our communities to make progress. And they said, they presented data, you know, for the last 5 years. And I'll show in the next slide, I'll show you the data that they shared with me. And they said, would you be willing to help us? And he also said, for the last 3 years, we had been having this cultural competence committee trying to make changes in terms of accessing services, but it hasn't worked out well. We know what you do. We know what your center does. Would you be interested? And we jumped to that opportunity for many reasons. So this is actually a 5.5-year project funded by the Mental Health Services Act. I don't know how much you know about it, but it is a remarkable funding since 2005 that you know, taxes 1% of those who are making $1 million or more. And at that time, there were 46,000 of those folks in California. So it really raises over $2 billion a year. And it's been, I mean, I don't know, $26 billion since it was. It is an incredible set of resources that constitutes about 90 to 20%, in some counties even more, of the operating costs of the county, okay? So the money came from the Mental Health Services Act. The other thing is that they asked us to focus on these 3 communities here, in Latinos, Filipinos, and LGBTQ. They had data for Latinos and Filipinos, which is this data that I'll share with you. Also, the work that we did was anchored on the cultural linguistically appropriate services standards, CLAS standards. How many of you are familiar with the CLAS standards? You are exactly the audience that I want to talk to, because this has been around since 2001. And it is, you know, one of the it has become very, very well accepted. If you know about the Joint Commission that accredits, you know, your medical center here, our medical center at UC Davis, they use the class standards to fulfill the elements of performance on person-centered communication and on health equity, etc. So please familiarize with it. I would strongly recommend. And then, as far as we know, this is the first project that combines class with community engagement. So this is the data that they presented to us. These are penetration rates by race and ethnicity in Solano County. And by the way, Solano County, you cannot miss it if you go from San Francisco to Sacramento. There are 4 cities that you are going to hit: Fairfield, Vacaville, and Suisun, and there is another one. Yeah, Vallejo. That's exactly right. And so it is kind of a rural, urban, you know, it's a mixed county, but with lots of needs. So this is where we work for several years, and we continue to work with them. So look at this. This is from 2010 to 2015. These are the penetration rates, which is service utilization, mental health service utilization. And you see how flat it was for Latinos. And then turn out, I didn't know that the Asian and Pacific Islanders in Solano County are Filipinos. 76% of the Asians in Solano County are Filipinos. At that time, now it is about the same. The largest concentration of Filipinos in the state and in the nation, I'm told. But look at the tremendous differences between the other ethnic groups. At that time, Solano County wasn't collecting data on sexual orientation and gender identity. We help for them to collect data. Now they have data on that as well, but they are reporting on. They ask us, can you come up with a plan so we can present it to our board of supervisors, to the mental health board, and especially to the community members? I'd be happy to. We came up with this very simple model of 3 phases, as you can see here. First phase is to do a comprehensive cultural needs assessment. The second phase, it was the intervention. And we have been working with the class standards since 2006 because we got funding from the developers, you know, the HHS Office of Minority Health that gave money to California through a mechanism. It is a minority block grant. And they came to us, thankfully. And they said, we have money for 5 years. Would you be interested? And of course. So we have been working with the class standards for since 2006, okay? And we have done a lot of work, and I'll share with you a little bit about that as well. So intervention, it was to train 3 cohorts of about 20 people from representatives from the county staff, community leaders, community-based organizations, but also on purpose, we included representatives from other sectors, social services, churches, schools, law enforcement, transportation, because when people don't come and use mental health services, they go somewhere else, you know, social services especially. And the third, and by the way, on the second phase, I'll tell you a little bit more because I have a slide about that, but we are expecting that the participants that we train, heavily train, that they are going to come up with action plans that we call quality improvement plans. And then the third phase is the implementation and, you know, of those action plans. So those are the 3 phases that we provided them. And by the way, they decided to call it, you know, a long name. We call it ICCTM because that's what they wanted to call it, and it is their model now. You know, interdisciplinary cultural competence, cultural transformation model. Okay, long name, cultural transformation model for short. So this is what we did in those three phases, and I'm going to go through this very, very quickly. During the first phase, we collected stories, histories, and it was very important to collect also strengths and assets that this community have, because too often when we do these community needs assessments, we look at deficits and we forget that they have absolutely assets and strengths. So we did it with the three communities. We did over 200 key informant interviews, a bunch of focus groups. We did several community forums as well. We have, here you see 1.0. Well, we got to 3.0 and perhaps beyond that. Identify the challenges and develop community narratives. That all of this is available, by the way. And we have them in English, Spanish, and Tagalog, because we endeavor to do that as well. Second phase, this is, you know, we did a series of trainings as well that they call Cultural Competency 101, 102, and Train the Trainers. Developed and conducted what we developed with the funding from the Office of Minority Health through California, the Department of Healthcare Services, a toolkit curriculum that we developed that we call Providing Quality Care with Class. Okay, and we have been, you know, utilizing this since 2007. That's when we had a draft of the curriculum. And then train, as I mentioned to you, three cohorts of the cross-sector representatives, and they developed 14 quality improvement action plans, okay? We, on purpose, we put them in small groups so they could use the class standards, 1 or 2, or usually we encourage them to use 1 or 2 to guide their work. This is the third phase. We coordinated the implementation of quality improvement plans. So what we did was to work with 4 CBOs. Actually, we work with 3 CBOs, and they develop their own action plans as well. I have a slide that I will just very quickly go through that as well. We did other community forums, and you know, you see the timeline until we had the final evaluation report. These are the community partners that we had fighting back based on Vallejo, and they focus on Filipinos. We had Rio Vista Care focus on Latinos, and we had Solano Pride Center focus on LGBTQ. This is in Fairfield, Vallejo, and Rio Vista, which is one of the cities in Solano County. And very quickly, I won't get into detail, but there are 15 national cultural linguistically appropriate services standards. The class standards got a facelift back in 2012, and they included one more, you know, and this is how they are organized by themes. The principal standard, standards 2 to 4 are focused on governance, leadership, and workforce. 5 to 8 on communication and language assistance, you know, providing interpreters and providing, you know, translation services. And then the one from 9 to 15 about engagement, continuous improvement, and accountability, which is of critical importance in all of this. This is a very busy slide, but I want to just focus on our toolkit curriculum that we developed from 2006, basically to 2008. And we tested it with different organizations at the state and at the local level as well. And it's called, once again, Providing Quality Care with Class trainings. So we organized the trainings, very intense trainings, in 4 sessions of 4 hours each, okay? The first session is that we provide a overview of health disparities and very in-depth. You know, these are 4 hours of training. And then the second is on community needs and gaps, and we use the community narratives, you know, the needs, the experiences that the populations that we focus on had on using or not using mental health services. You know, we were critical because that's what we heard. And Solano County, I give it to them. They took it on the chin, and they were very graceful about it. They were not defensive, but if you take a look at the narratives, really they describe some of the challenges that these populations were having in accessing care. The third session is based on the class standards, and that's when the participants start developing the action plans or the quality improvement plans. By the 4th session, they use it to refine the quality improvement plans, and then we also do coaching, 6 to 8 months, monthly meetings with the small groups that develop the action plans as well. It's very structured, you know. We have learned through the years on how to do this. This is just to give you a sense, so you have a feeling of how that transpired. This is one of the cohort 1, and some of the things we do it very interactive. Okay, engage them right from the go. And the other thing is that the leadership from Solano County was asked to come and give the blessing. Okay, say this is totally supported by the leadership of Solano County. You know, that was a requirement from us as well. A little bit more. And I'm the one who took the picture, so I'm not in the picture. These are the 14 quality improvement plans. Along with Solano County and the community partners, we organize them under community focus, CBO defined, workforce focused, and training focused. And the names that you see there are the names that the small groups that created the action plans gave them. You know, so you have mental health education. I'm going to show you a little bit about the taking class to the schools, a little bit about the True Care roadmap. I'll share with you a little bit about the ICU here, which is the training focus. And I have just one CBO defined as an example of that work. This is precisely the CBO defined. This is Rio Vista Care supporting the Latino community. That was the primary focus, the population of focus. But they, of course, they provided services to anyone who came to receive services. And there is a lot of information here, but what I want to emphasize is that some of the lessons learned was a trusted community partner is important to deliver mental health messages. And trust emerged over and over again about the importance. Actually, one of the things that we did with the county is that there was distrust from the CBOs to the county, okay? And we did a lot of work having community engagement front and center in order to kind of bring them together. And at the end of this experience, the county, when we did kind of exit interviews, the county said that the most important lessons that they learned were on community engagement and the importance of developing trust, building trust, and also becoming a trustworthy organization, because they were not. That's why we captured that in the community narratives, and they were good sports, for taking that on. This is taking class to the schools. This is a wonderful, wonderful action plan or quality improvement plan. Has been very successful. And basically, this is to create spaces for adolescents primarily, although some of them are for older adults. We extended that to older adults. But if you can imagine, this is a space, this is an actual picture, and the youth, they decide what kind of furniture, they wanted to have in their spaces. And there are 47 wellness centers on school campuses, K through 12, and also including the juvenile justice facility and the Solano Community College. One of the senators, Senator Bills, who was the chair of the mental health caucus, he took on this, and worked on legislation and came up with resources to focus on this work. There are many other details that, because of time, I won't be able to go through. This is just another example, because one of the things that we endeavored to do when we were doing the community needs assessment was the whole person model. We asked, what has been your experience if you have come to services at the Behavioral Health Division in Solano County? When you take buses or you park, and then you walk into the reception, and then you have the clinical encounters, all the steps. And one of the things that we encounter is that a good proportion didn't return because the experience that they had, when how they were received. Actually, there is data that when Latinos, for example, finally get into the doors of service, over 50% of them don't return for a second time. And it is because how they felt during the first time. So this, I see you, it was on purpose, and this is the name that they decided to do, to say, yes, you are the focus of my attention. That was a very important message that wanted to be sent. So what are the outcomes? And I wish to have much more time to really share with you more outcomes like than these three. One of the outcomes is that there was a significant increase to the access line calls. And as you can see, in the case of Latinos, it increased by 90%, Filipinos 32%. And this is, well, actually it's not. That is improvement in intake assessment offered within 10 days. They improved that significantly, okay, by those percentages that you see here, you see there. But here, overall, there was an improvement in access line calls by 29%, over 300 with the LGBTQ. That was dramatic. And in Latinos, over 30%, and in Latinos, about 41%. This is something that the county is very happy about. And they have highlighted that these populations, Latinos and Filipinos and the LGBTQ, when they access mental health services, it was through the crisis services, which tend to be very expensive and not as effective. You know, so what they saw was a decrease in first admissions through the crisis services, and you see the percentages reduction here, and increase in patient services. But I want to share this with you. These trends reflected increased trust toward primary mental health care providers in Solano County and resulted in substantial cost savings. We had a wonderful, wonderful evaluation team, including a health economist. And I wish, I really hope that I piqued your curiosity so you can take a look at the report, the final report, and see in more detail the contributions of each of the evaluators that we had. A wonderful, wonderful team. This is yet another. We focus also on provider outcomes. And what I want to emphasize here is that nearly 100% of the behavioral health staff reported that their job was meaningful. And you have different numbers there. But there was an increase in all of these areas: perceived influence, job meaningfulness, perceived effectiveness, perceived inspiration, and job satisfaction, which wasn't as high as the others, but still there was an increase. This is the final evaluation report. I'm very proud of it because it is full of infographics, and I would encourage you to take a look at it. And if you have any comments or questions, please send me an email. We'll be happy to respond to that. So, you know, I had just a few minutes to share 3 outcomes. If you are interested, I'll be happy. You will see many more outcomes in the report itself, but we have other summaries about what we accomplished that in a minute I'll tell you more about it. But the answer is yes, mental health equity can be advanced. This is we documented that, and very proud of that work. So what we are doing now is that this called the attention of the Mental Health Services Oversight and Accountability Commission, which were the funders of this project to begin with. And they said, oh my God, you guys have something there. Why don't we, would you be willing to create a learning collaborative for any of the counties that would be interested in receiving training? And of course, we said, be happy to. And this is exactly where we are right now. There are representatives from 44 counties in California and participating in 2 cohorts. And there are the participants are basically the ethnic services managers and the equity services managers, but also some of the leadership as well. But not only the counties, we are training also folks from the Department of Healthcare Services, from the California Director Behavioral Health Association, and others who are interested in this training. We have a full year training in 2 different cohorts, and these are the topics, the training topics that you can see here. We are about to begin this one. This is 3 of the sessions are going to be focused on community engagement, because the county and the community said, this is what we would like to see happening. And the counties are very, very interested in that. I'm going to be providing a training on Tuesday, this Tuesday, with Lloyd Michener, actually. Lloyd and I, and Lloyd is a national expert on community engagement as well from Duke. That's why I'm looking at Bob here. And we have been working together for 15 years or so. So he and I are going to be training the first cohort, and then towards the end of the month, the second cohort on the first part of the community engagement training session, okay? But there is something else that, and there is this mentor-mentee component. There are 4 mentee counties. Can you imagine? Solano County, 500,000 people, is training mentee LA County, 10 million people. is just remarkable. And also Kern County, Fresno County, and Marin County. They are included in these mentor-mentee counties. I have to brag a little bit, okay? And Lisa, this is the meeting that we were in, which Mike Kurilla presented this slide. This is in the CTSC annual meeting that happened just recently, relatively recently. And Mike Kurilla, we got second prize in the Association of American Colleges 2002 Community Engagement Innovation Award. And I'm so pleased that my dear friend Linda Kotler with the Health Street model, she got the first prize. But we have been getting some recognition about this work as well. So some lessons that I want to share with you. Multi-stakeholder community partnerships are required. It's important to use a health equity lens. Listen attentively to all and treat partners with dignity and respect. This is so critically important. Review, include community members and IRB committees. This is also very important. Review local data on health outcomes in your community and connect the dots, and look for what is missing, the gaps. Actively look for community assets and strengths and resilience and use them, which is the point that I was making earlier. Design and implement for sustainability right from the go. Start, don't overplan, learn and adapt as you go. And because we are in this academic setting, it's important to include students, trainees, and in the research. But I want to emphasize this one. Building trust and creating trustworthiness are front and center, okay? Patricia, Lisa, you know that. Your work with promotoras is admirable, truly. And it is because they trust. And you are doing some good things well. But I think that I gave a talk at the University of Florida just a few days ago. And I came up, I woke up at 4:30 in the morning Eastern time, you can imagine. I said, oh, there are these 4 S's, is you have to be sincere, simple, and shut up and listen as well. And also it's, I don't want to, it is the community S instead of it is the economy S. I don't want to say this in online, but that is the other one that is of critical importance, okay? Simple kind of rules. We have been working, by the way, on this National Advisory Council, this is the National Academy of Medicine for over 4 years. I'm a co-chair of this work group that is called Assessing Meaningful Community Engagement Measures in Health and Healthcare. And has provided a roadmap. If you are asking, well, how do we go about doing meaningful community engagement? Well, this is a roadmap. I don't have time to really go through each of the elements, but it took us years to come up with this conceptual model on assessing community engagement. And we reviewed over 20 conceptual models. And look, guess what? Community engagement is front and center, guided by several principles. There are 4 different domains like strengthened partnerships and alliances, expanded knowledge, improved healthcare programs and policies, and then thriving communities. And I love the dynamism of, some people call them pedals or propellers, but it is how dynamic this is. And then what I want to call your attention is the connection between community engagement, building trust, and becoming trustworthy to health equity and transforming systems for care. And all of this is, under the context of the drivers of change, and those are the social, political, racial, economic, historical, and environmental context. These are the determinants of health. Okay, this is, by the way, I think that is next week on the 6th, May 16th. We are going to be releasing the measures, the measures, 28 measures after reviewing almost 1,500 articles. We came up with 28 measures. And the measures tap into these elements that you see here, okay? Under these 4 buckets that you see here. And also we are going to be releasing 7 impact stories. 2 of them videos. I think that I showed you one of the videos. I gave a sneak preview, the one by Debbie Oroken, which are going to be powerful. And this is coming up very soon. Now I'm just have a few more slides, if you allow me. And this is we have been working on innovative models of health service delivery for underserved populations, because health inequities and mental health inequities have been around for decades. It's unacceptable. We need to do more about it. And these inequities were even more pronounced during the pandemic. So we need new service models. And this is what we're hoping to do, Bob, on go to where people are. And there is a good reason for that. I don't know if you're familiar with the ecology of medical care. It's been around since the 60s, okay? And it's been revised and revisited and reimagined. And basically, it is that if you have from the street 1,000 persons, about 800 are going to report symptoms. Over 300 would consider seeking medical care. And then 1 out of 5 will visit a physician's office. But you can see what happens down the road. 21 visit a hospital outpatient clinic. But look at this. I just met yesterday with some of the UC regents, with our top UC Davis Health leadership as well. I presented this to them as well. And I said, look, less than 1 out of 1,000 come to a hospital like ours. And of course, it is very important because it's a matter of life and death, But this is, and the reason for that is because the prevailing model of service delivery has been the waiting mode, as I call it. Come to us, we have these wonderful buildings, and no criticism about that. That is important and necessary. The primary care networks, that our academic health centers have as well. But we need a paradigm shift from the waiting mode, rather than waiting for patients to come to us. We ought to move into a seeking mode. We have the technology to do that. We have the know-how on how to do that. We need to go to them where they are. And this is what we have been doing, especially during the pandemic, bringing testing, vaccinations, as well as other services through using telehealth services, by the way, that we have had at UC Davis, something we call Express Care since September of 2020. And it is amazing that I got COVID in November of this past year, and I use Express Care. And in 10 minutes, I was being seen by a physician, an emergency doctor who prescribed remdesivir. And I was, taking the infusion that same day, for 3 days in a row. My wife got COVID also, and she used Express Care. And boy, in less than 3 minutes, she was being seen by a doctor. She was in LA. And the doctor was so incredible that she even determined which was the closest pharmacy that my wife or my daughter could go and pick up the medication. So my wife could start with that. Last night, I was I was having dinner here at the shopping mall, close to the hotel. And this dear friend, this is the ambassador and consul general of the Mexican consulate in Sacramento, who is very sick, and I hope that she allows me to share this with. But I saw her on Tuesday night, at a very important meeting, and and she's the one who co-led the trip to Mexico City that we recently had with our chancellor, she got a very this respiratory problem, and she said, "Do I go to the emergency?" And I said, "Use Express Care. Get into my chart and get into Express Care." And she did. And it is amazing that I have been communicating with her that she's under medication right now. I'm hoping that she's doing much better today. But just to illustrate, that we have the technology to do this. I have been doing population-based research for a long time. And this is just to share with you what are some of the institutional barriers that we need to overcome. Look at this. Over 52% of the sample that we did back in the 90s said, I wouldn't know where to go. 50%, I have no way to pay. There are no treatment centers near my home. Transportation is an issue as well. I can go to the clinic during open hours because they work, long hours. I can go as frequently as needed. So we got funding from a congressional earmark, Representative Doris Matsui, who is my congresswoman in Sacramento, was instrumental. She was a champion to get us this money that you can see here. And I love this quote from her. To truly achieve health equity, we need to ensure everyone can have access to the highest quality healthcare that enables and empowers individuals to optimize their well-being. And this is what we are doing with the Digital Health Equity Program, is to bring health services to historically underserved patients and make access to healthcare more convenient and feasible, going to where they are, where they live, where they work, and where they congregate as well, going to where they are. We got funding, serious funding, first from FEMA and then from the California Department of Public Health, from a project that we call Move It Up. And it was to increase the percentage of Latinos and African Americans who are vaccinated. This was testing and vaccinations. And this was, just to brag a little bit, that Secretary of Health visited the Move It Up vaccination clinic, the last one that we had, after months of working in September 3rd, and he launched the Latino Health Tour in that visit. It was fantastic to have him here and to really, it really was inspiring. What was the outcome of that, the Move It Up? Well, we provided over 6,000 vaccines. You would say, big deal, 6,000? Well, it was a big deal, let me tell you, because we went to where people were, where they live, where they work, where they congregate. And it's not easy to establish trust. We needed to go repeatedly, week after week, and to be a constant presence in order for them to be, oh my God, I'm sorry. This is, we did what we set out to do because this is 50% to Latinos, doubles the proportion in the population and then this also is like 30% above the presence of African Americans where we were working. We are working right now in this integration of the Move It Up, which is now phase 2, and the Digital Health Equity Project. This is exactly what we are doing. We go to where people are. This man was positive, and on the spot, we put them in touch in no time with the primary care physician, right there. And the physician prescribed Paxlovid. And not only that, they went to get the Paxlovid for the person, you know. And finally, this is the last slide, I promise. And this is, you know, work with the Stanford. I'm excited for that work with Bob Harrington and also with Paul Wang and other colleagues here. And this is the project 5 of 5 projects that we are proposing. And that is to do telehealth and healthcare delivery model for mental health, substance use related services, and cardiovascular health conditions in underserved populations. And we are going to use this as an innovative model of health service delivery in close collaboration with fairly qualified health centers, which is what we are doing to increase access to mental health services and prevention of cardiovascular risk factors with these improved outcomes that you see there. So I'm finishing here. You know, I always recognize there is nothing that I do by myself, nothing. You know, sometimes you know, they are the ones that have done the work primarily. Let me stop here. Thank you so much for.
Sergio, thank you so much on the behalf of our Stanford community for sharing with us such inspiring, innovative work. Thank you for elevating the importance of community engagement, for sharing with us a model to advance health equity. And also thank you for everything that you do in our local community, in our nation, and also globally. I believe we are out of time.
Yes.
Thank you to our online audience. If you're here in person, this is a benefit of being in person. Dr. Aguilar-Gaxiola will hang around for a little bit.
Yeah,
So please come forward, ask questions, meet him. We're so lucky to have you here. I'm so glad you have so many partnerships and projects here with our Stanford community.
Yeah, thank you so much. And you have a meeting at 9, so please go. Yeah, thank you again.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.